these issues. Now we come on to the odd man or the odd woman out among us, retinal surgeon. So Dr. Akanksha Rai will be talking about the retinal causes for unhappiness in a post-cataract patient. Over to you, Dr. Akanksha.
Thank you, sir. Good morning, everybody. So I'll be talking about the retinal causes and management in an unhappy 6/6N6 patient post-cataract surgery. And first of all, let me thank my mentor, Dr. Soni Jos sir, and AIOC Scientific Committee for providing me this opportunity in this wonderful instruction course. So with this, as we know, that advanced surgical techniques have improved the outcomes of the cataract surgery, as well as the patient expectations have also increased. And also there are pre-existing conditions, retinal conditions, which cannot be diagnosed pre-operatively sometimes due to the cataract haze, or it might be induced post-operatively, leading to a 6/6N6 unhappy patient. So with this background, I'll be showing few cases which I have got from my cataract department, and then we'll go on to the discussion. So this is the first case. A 58-year-old lady came to us with a pre-op visual acuity of 6/18. She was diagnosed to have cataract in the left eye, and surgery was done. It was an uneventful surgery. Post-op visual acuity improved to 6/6. Post-operatively, she started complaining of a black dot in front of her left eye, operated eye. We went ahead and saw her fundus again. There was nothing in the fundus. OCT scans were reviewed, and in one of the sections, as we can see here, there was a hyperreflective dot in the inner retinal layers and a hyporeflective dot in the outer retinal layer, which was typically suggestive of solar or a photic retinopathy. On further interrogation, she accepted that recently she has started worshipping sun god, and history of solar gaze is there. And this was an example of solar retinopathy, which was picked up post-operatively. So if a thorough retinal investigation was done, it would have been picked up earlier. Okay, so this, the second case is a 65-year-old lady. Preoperative visual acuity 6/36 improved to 6/6 parts. Surgery was uneventful, and even having 6/6 parts, she complained of blurring of vision in the left eye. Again, we went back and saw her fundus. Now we can see very small subtle changes in the fundus, as we can see here. Along the superior arterial arcade, there was cholesterol plaques in the artery, which is suggestive of some old arterial occlusion. Also along the inferior arterial arcade, we saw small retinal hemorrhages in the nerve fiber layer, superficial retinal hemorrhages, suggestive of a venous occlusion. So with these two things, we came to a conclusion that there is some vascular compromise in this eye, and the decrease in vision probably is due to the macular ischemia due to these vascular events, and she was referred to a physician. The third case was a 58-year-old gentleman who came to us with cataract, and post-cataract surgery, his vision improved to 6/8 parts. Surgery was uneventful, but he was typically complaining of a black horizontal linear band in his inferior field of vision, which he was very sure that there is a linear horizontal band. We saw his fundus. On fundus, we found that there was a white horizontal lesion above the fovea, suggestive of some small arterial occlusion, along with thickening of the retina, and the corresponding area on the OCT showed thickening, along with a hyperreflective band in the middle retinal layers, which is typical of parafoveal acute middle maculopathy, which is seen associated with vascular events in the eye, as well as systemic vascular events. So here the patient was investigated further for systemic conditions. On systemic examination, he was found carotid Doppler showed diffuse atherosclerotic changes in the left internal cerebral artery and the common carotid artery, and a bifid curve in the right internal carotid artery. So by looking at the eye, we came to the diagnosis of these systemic things, and the patient was referred to cardiologist, and medication started. In this case, the most important thing is we counseled the patient about the guarded visual prognosis in this eye in future. So there are also previous case reports where identifying a paracentral acute middle maculopathy has led us to detection of the systemic conditions. This condition is actually a focal ischemia of the deep retinal circulation that may herald the presence of secondary underlying condition. OCT is invaluable in identifying this condition. OCTA shows us a capillary loss at the deep capillary plexus level, and the patient typically complains of a paracentral scotoma, and the vision may or may not be decreased. So these patients need warrant a thorough systemic evaluation. The fourth case, this case was our old case, which was a known case of retinal pathology, which we were being following her up for past 4 years. Post cataract surgery, her vision improved to 6.6, but she was complaining of blurring of vision in the right eye. So as we can see here in the fundus image, there is straightening of the retinal vessels along with a membrane, a shining membrane over the fovea, which is suggestive of epiretinal membrane. And the OCT also shows grade 2 epiretinal membrane where the foveal contour is lost, and nasal to the fovea there is thickening of the retina, but the vision was still good 6.8 because the epiretinal membrane was not distorting the fovea, and it was distorting more the parafoveal area. So the vision was preserved to 6.8 parts, and we are following up this case. Here, since the patient was counseled before the surgery that she is having an epiretinal membrane and the visual outcome will be suboptimal, there were no much complaints from the patient side. The fourth case is also our old case, and she was being followed up by us. She came with cataract, operated, vision improved to 6.6 parts, but after surgery, she was complaining of blurring of vision in the left eye, and she was a case of parafoveal telangiectasia, but since the patient was a known case of parafoveal telangiectasia, there was no much unhappiness from the patient side, and she was counseled beforehand. So with this, with this background, I'll come to the other causes which can lead to 6.6 and 6 unhappy patient retinal causes. It can be divided into vascular, inflammatory, degenerative, and dystrophy. The vascular can be minor arterial or venous blockage can be there. In case of arterial or venous blockage, we have to go ahead with the systemic investigation and refer the patient to the physician or the cardiologist, whatever is required in the cases. Also, the other causes for unhappiness can be small, like there can be a mild vitreous hemorrhage, post-cataract surgery from the peripheral neovascularization, and during the surgery, vitreous is disturbed, and which has led to a small amount of vitreous hemorrhage. The next cause is inflammatory, can be pseudophakic cystoid macular edema, which can be treated with topical NSAIDs pre and post-operatively. Old uveitis, which might be missed pre-operatively or flared during the cataract surgery. Subclinical endophthalmitis can be there with low virulence organisms like GPC. Masquerades and photic or solar retinopathy. Subclinical endophthalmitis should be treated in masquerades, but photic and solar retinopathy have a very good visual prognosis, and they only need is observation. Degenerative causes can be complete or incomplete PVD induced during the surgery. Subfoveal or fovea awaiting drusen, which needs observation only. Asteroid hyalosis can be there. Usually asteroid hyalosis patients don't complain of any visual, they don't have any visual complaint, but rarely post-surgery, these asteroid bodies can come and they can get accumulated behind the nodal point, and then the patient can complain of decreased vision. In those cases, only vitrectomy or YAG laser vitreolysis may be needed. Other degenerative causes are parafoveal telangiectasia and epiretinal membrane, which I showed in my previous cases. If they are present, they need to be followed up, and if at all they are progressing, they need treatment. The last one is the vitreomacular adhesion or traction. Sometimes what we think as a vitreomacular adhesion can be a vitreomacular traction, which has led, and the vitreous movement during the surgery has led to mild cystoid macular edema, leading to patients' unhappiness. In those cases, we have to do ultra high resolution OCT, because standard resolution OCT is capable of 10 micron axial resolution, which can miss small amount of macular edema or a cystoid macular edema. But if we go ahead with the ultra high resolution OCT, which is capable of 3 micron axial resolution, if a small amount of cystoid macular edema will not be missed, and if at all there is small macular edema in these unhappy patients, can be picked up with ultra high resolution OCT. Other than this, there can be a dystrophy, early retinitis pigmentosa sign pigmento, where the fundus is not having the typical features of pigmentation in the periphery, and post cataract surgery, the patient will be unhappy. So with this, the take-home message is selection of cases for multifocal, trifocal EDOFs should be very stringent, and detailed preoperative retinal evaluation and imaging is important to select this patient. And here, since the vision is 66N6, most cases will not need any intervention. The retinal lesion is very small, non-progressive. They only need is preoperative reassurance and proper counseling. Thank you so much. These are my acknowledgement.
Thank you very much, Dr. Akanksha, for that very descriptive causes, and makes me a little more scared when dealing with these patients because a few of them are unknown to me. Thank you very much for making it very